Hey guys, welcome to another episode of 3 Minutes Cases in your channel Radiologist Creed. Uh, Today we have some cases of head and neck emergencies. Uh, this is the first case. These are some selected images of a non-contrast CT axial slices of the brain. Please take a moment to examine it. In these images we can see there is a crescent hyperdense collection in the extraaxial space and that crosses the suture lines but limited by dural attachment. This is a case of acute subdural hematoma. These are some teaching points. The acute hemorrhage is usually seen as a result of severe head trauma or high velocity acceleration or deceleration head injury. The chronic subdural hemorrhage is usually caused by more trivial trauma in patients with some risk factors like old age or chronic alcoholism or epilepsy or some cases of coagulopathy. In children, the neonatal hematomas may be related to delivery, and these usually resolve, but in some infants or toddlers, the non-accidental trauma must be suspected. It typically overlies the convexity, although the posterior fossa hemorrhage may occur also in mostly in children. Subdural hemorrhage may be symptomatic even when small, especially in young patients. The density characteristics are not an absolute indicator of the relative timing of the hemorrhage. This is the second case. Please take a moment to examine these non-contrast CT. In this selected axial and coronal CT of the brain, soft tissue window and the bone window, we can see there is a large right parietal epidural hematoma involving the rupture of the middle meningeal artery that causes severe mass effect including leftward midline shift and some compression of the lateral ventricles, and there is a heterogeneous density within the hematoma that reflects recent and possibly active extravasation, and this is marked by the long arrow. There is also a non-displaced fracture in the right parietal bone marked by the arrowhead on the bone window coronal image. The anterior-inferior margin of the right parietal epidural hematoma is bounded by the temporoparietal suture, and there is a small left frontotemporal subdural hematoma on the left side. This is a case of extradural or epidural hematoma. This is the third case. These are selected axial non-contrast CT. There is a hyperdensity consistent with the subarachnoid hemorrhage outlining the left precentral gyrus. There is also subarachnoid hemorrhage outlining the right sylvian fissure and infiltrating the sulci on the right temporal loop. There is also some traces of hemorrhage intraventricular, which is seen layering in the occipital horn of the right lateral ventricle. There is also some subarachnoid hemorrhage in the prepontine cistern, and there is a subdural hematoma overlying the left temporal and parietal and occipital loops extending along the phalanx and left tentorial leaflet, as we can see here. This is a case of subarachnoid hemorrhage associated with some subdural hemorrhage. The head CT is the most appropriate first examination to evaluate for subarachnoid hemorrhage. We do a lumbar puncture, which is more sensitive than CT for detection of subarachnoid hemorrhage. It may reveal the evidence of chronic subarachnoid hemorrhage seen as vansochromia. The MRI is relatively less sensitive for early subarachnoid hemorrhage, especially the conventional T1 or T2, yet the flare may be better than T2. Also very sensitive for chronic subarachnoid hemorrhage. It may produce strong susceptibility signal seen based on the gradient images. Traumatic subarachnoid hemorrhage is strongly associated with other forms of traumatic brain injury like contusion and diffuse axonal injury. This is the fourth case, which is for a 44-year-old male who had an upper respiratory tract infection for weeks before developing a headache and fever. Please take a moment to examine these selected images of the MRI scan, T1 weighted images and contrast, and this is the flare and diffusion weighted images. There is diffuse backmeningeal enhancement and some scattered leptomeningeal enhancement. There's also diffuse sulcal hyperintensity on flare images and diffuse cerebral cortical high T2 signal intensity and high in flare and diffusion weighted images, with also mild disproportionate prominence of the ventricle relative to the sulci. This is a sign of early hydrocephalus. Also, there is layering of diffusion weighted images, hyperintensity representing pus in the lateral ventricles. This is a case of meningitis, and also usually the imaging findings of the meningitis are non-specific and may evoke a broad differential diagnosis. It's usually narrowed by consideration of the clinical presentation. This is another case of showing CT, and these are the MRI T2, T1, and post contrast. On T1 there is hypointense cortical and subcortical lesions, which is high in T2 and flare, and these lesions shows variable patchy enhancement. And on diffusion there is restriction of the diffusion in these images. This is a case of PRES or Posterior Reversible Encephalopathy syndrome, and there is a differential diagnosis for these cases listed as some teaching points on PRES. This is a neurologic disorder and which is characterized by particular radiographic findings and must be combined with clinical manifestations of headache, mental status change, seizures, and visual disturbances, associated mostly with preeclampsia, acute and subacute hypertension, drug toxicity, like mostly chemotherapy agents, autoimmune disorders, and sepsis. Thank you.